Good afternoon all. It looks like a few are starting to join us now, so I think we will make a start. So welcome, my name is Lorna Quinn and I'm Public Health Intelligence Principal based at Rotherham Metropolitan Borough Council. Really excited to be here today hosting this session, which is one of the LGA's Public Health Lunch and Learn series. I suspect some of you may have attended the session last week, which was around innovation in early years nutrition, which is evidence, co-production and local impact. Really exciting that the LGA has been running this programme each Thursday since March, and in the Q&A we will put a link to future events, so please do take a look and book onto any of those that might be of interest for you. Today's session will focus on why the first 1001 days of life are critical for children's mental, physical and social development and what this means for our local services. We'll be discussing the Healthy Child programme and the role that local authorities play within the delivery of that. We will look at England's core offer of 5 mandated health and development reviews, of which I will talk a little bit more about shortly, alongside the evidence from 2 National Institute for Health and Care Research PHIRST evaluations of areas going further. One of which is here in Rotherham, which is really exciting, introducing a 6th visit to our already mandated 5 visits, and then one in Camden, which expanded the visits to 8 in total, so 5 through to 8. We've got 2 great speakers with us today. We have Nathan Davies, who's a Public Health Registrar and NIHR Doctoral Fellow based at the University of Nottingham with the NIHR PHIRST Light team, and Sarah Janac, who's a knowledge broker for the NIHR PHIRST Elevate team based at the University of Edinburgh. Just a little bit of housekeeping points before we get going. We will be using the Q&A function for today's session. Now the chat has remained open, so feel free to post any contact details or links in there. But if you're asking a question specifically, please do post that in the Q&A function and use the upvote to vote for questions that you prefer to be answered sooner, and we'll go through those by the most number of votes at the end. We will be sharing the slides and the session is being recorded. However, please do note that the Camden evaluation is still in early stages of that evaluation, so there will be a final report shared later in the year, but these are just some initial findings. If you wish, you can enable live captions for the session by clicking on the caption buttons in the More drop-down on your Teams account. And we are aiming to have 15 minutes for Q&A at the end of the session. So as mentioned, please do pop those in the chat. So thank you again for joining us, and I'll just start to give just 2 minutes overview of the Healthy Child programme, what that means, just in case colleagues aren't familiar with that. So the Healthy Child programme is a national framework for improving health and wellbeing of children aged 0 to 19 or 25 for care leavers or those with special educational needs and disabilities. It is funded by the UK central government by the Public Health Grant, which is then located to individual local authorities. There's over 850 million annually invested in supporting this health visit, and that includes a skilled workforce, including those health visitors. It's structured into 2 sections, so pregnancy and early years, which is around those aged 0 to 5, delivered by health visiting teams, and then school years, which is 5 to 19, delivered by school nursing teams. Here today, we're specifically focusing on that early years element, where there's 5 statutory health and wellbeing reviews. Probably note we do use the term review and check interchangeably throughout some of this presentation. It's just local language versus sort of the national strategy language. And these are antenatal, new births, 6 to 8 weeks, 12 months, and then 2 to 2.5. All reviews should focus on parental insight, professional knowledge and observation, and the use of different observational and development tools. So, for example, the Ages and Stages questionnaire, which we'll talk about shortly, or ASQ. And all reviews should support national priorities, including sharing information around promotion of immunisation uptake, family planning, reinforcing safe sleep, guidance on safety and supervision, and family health education. Now, although there are 5 statutory mandated visits, what we will hear now is how there's option to expand those or add additional visits into that. So we will hear from Sarah and Nathan around other additional visits that could be implemented as part of the Healthy Child programme. And with that, I will pass to Sarah to give us a description of the NIHR PHIRST scheme and talk to us about the Camden service. So over to you, Sarah. Thank you.
Hi, thanks very much, Lorna. So that was an overview of the Healthy Child programme. Before I sort of dive into the what there's in Camden and the valuation, I'll talk very briefly about how the valuation came about. Um, it's part of the Public Health Intervention Responsive Studies Teams programme. So some of you may have heard of it. Some of you might even have got a first evaluation in one of your local authorities. So I'll just give a brief overview for those who might not have heard of it before. So first, I'll talk about the acronym first with a PH, which is stands for Public Health Intervention Responsive Studies Teams, and a bit of context of that. So, we all know that local governments have great opportunities to influence health and health equalities, but at the same time, there's often a lack of an evidence base. And we also know that there's lots of really great interventions that are being delivered, especially with the little evidence that is available. And that means evaluations are necessary. And public health practice in local government has often been fairly distant from academic research. So taking all these together, there really is a golden opportunity to learn. And these could be lost, these opportunities, which is how FIRST comes in. It's a scheme that consists of 10 academic teams, and they undertake evaluations of public health initiatives run by local governments across the UK, and the evaluations are free to the local governments. It was first commissioned in 2020. There's now more than 50 completed evaluations, and there's more than 40 in progress. And evaluations report relatively quickly for well, from the academic perspective at least, in 12 to 18 months. And it's not a sort of consultancy service where we come and do an evaluation and leave again. It's rooted in co-production. We put a lot of emphasis on public involvement and knowledge mobilisation. So how do you get a first evaluations? There's an expression of interest or a call for expressions of interest twice a year. So that's advertised through the NIHR First website and the newsletter, and local authorities submit to that, submit an application for that. It's not that long. I think it's about 2 or 3 pages. And those applications are then shortlisted by NIHR, and if successful, they're allocated to one of the FIRST research teams. And these are the 10 teams that currently exist. I'm up in the one in Edinburgh, the red one there. And I guess to note here is that geography doesn't play a huge role in the allocation process. There's different factors that play a role, thinking especially about the sort of expertise of the team, of the research team, and how good a match that is for the evaluation that needs done. There's also a FIRST website if you haven't come across that yet, so you can look at all the evaluations there. So here's a map to showcase where evaluations have taken place so far. And you can also have a look based on different topic areas and see if there's an evaluation there that might be of interest to you. So do have a look if you like. And some ways to stay in touch. There's a newsletter, various social media accounts. So yeah, do have a look. And if you have any questions on the FIRST scheme, feel free to get in touch. So that was a very quick overview of FIRST. I'll move over to one of the evaluations now, which is Best Start for Baby. That's the programme we are evaluating currently in Camden Council. I'll be doing the presentation on this bit, and then we've also got Susanna from Camden Council who will be there for the Q&A. So what is Best Start for Baby? It is a programme that was developed in 2023 and is borough-wide in Camden since April 2024. It offers up to 8 enhanced health visiting appointments, so from antenatal into 2 years of age. It also offers there's other strands to it as well. So there's stay and play baby bonding sessions that are open to anyone. There's also targeted support and also specialist support, especially around perinatal mental health services or trauma-informed therapy. As Lorna just outlined, the contacts are underpinned by the Healthy Child programme, and they're delivered by lots of different practitioners across the community, across psychology, across health. So it's really a sort of huge interdisciplinary programme. And a big part of the programme is really the access to university embedded clinical psychology and the ability to step up that specialist support as is required. What we really focused on this evaluation is looking at the 8 enhanced appointments. So I know Best Start for Baby offers other strands as well, but we really just focused on those 8 enhanced appointments. So I'll come back to that when I talk about the evaluation. Best Start for Baby tries to improve access to support in the first critical 1001 days of life and reduce health inequalities in doing so. It really tries to enable the right support at the right time and identify emerging needs early and then intervene early to stop escalation. It's coordinated and relationship-centered care, and it's health, psychology and community services coming together. And as I mentioned earlier, the big focus here is on psychological support as well, and normalizing conversations about emotional well-being, infant development and parenting, and making people feel safe when they want to ask for support. And these are the appointments. These are the Best Start for Baby appointments. So there's 3 home visits early on, and then there's 5 additional appointments that are delivered in the community setting, so local family hubs. So I've circled the ones that are addition to the sort of statutory ones, and just it's a bit confusing, but the 9-month appointment is in Best Start for Baby, the 9-month appointment equals the 8 to 12-month mandated review. So the 12-month appointment is the additional Best Start for Baby appointment, and that would be important when we look at some of the data. Quick look at the Camden population. There's about 220,000 people in Camden, just under 10,000 under 5s, very ethnically diverse. White is the white people or the biggest representation in the population, but there's 20%, about 20% Asian, 10% Black people, and also mixed ethnic groups. And if you look at the sort of spread of deprivation, you can see there's not really there's kind of pockets of deprivation all across Camden. There's no big sort of area of more deprivation and less deprivation. And you can see that children from Black and Asian backgrounds are significantly more likely to live in the most deprived areas compared to white people. Something that is highly prevalent in Camden and really relevant to this evaluation is that there's a high population turnover in Camden, with many people moving in and out of Camden, which does pose a challenge for kind of recording health visiting and making sure everyone who is eligible gets their appointments. So the questions we set out to answer in this evaluation is, what is the reach of Best Start for Baby, and to what extent does Best Start for Baby reach families? And what are the barriers and facilitators to service engagement? And are there any patterns across the 8 appointments that are significant? And we looked at, and this was, we had quite a lot of chats with the team in Camden and tried to really narrow down which groups would be of particular interest. And these are the groups that were of particular interest for the team in Camden: Black African and Black Caribbean families, Bangladeshi families, those who have experienced perinatal mental health difficulties, dads, and families who live in temporary accommodation. And that includes families experiencing homelessness and refugees. So we really focused on those 5 groups, and we really focused on equity and reach and better understanding that. So what we did is we looked at existing data on appointment attendance across those 8 appointments, and we also did focus groups and interviews with families, especially the families of those 5 groups, and staff. So we had 50 people in total. To mention is also that we're still working very closely with a public involvement group, and they've been great. They've had a mix of backgrounds and experiences with Best Start for Baby. Some of them have moved into the area, some of them have a child who has not gone through Best Start for Baby and the second one has. So it's really good to hear the different experiences with the programme. And we meet every 3 months, and we just had one meeting this week, and they're currently helping us formulate the recommendations for the valuation. So they've been really great to work with. Early findings, first glance at what we found. So I'll start with the sort of quant aspect, looking at the attendance across the appointments. This shows the overall engagement and what proportion of families are attending all appointments. What does the engagement look like across the whole service? So this shows that about 2/3 of families are engaging fully, attending all appointments that are offered, and about 1/3 of families are only engaging partially. So I'd be really interested to hear, possibly later in the Q&A or in the chat, if that's something that you sort of recognise in your service, that sort of pattern, or if there's anything surprising there for you. Be really interested to hear. And this looks more closely at attendance patterns across the individual appointments. So the blue bars show the additional appointments that are offered as part of Best Start for Baby. And you can see that there's very clearly a sort of drop off for those appointments, the additional appointments that are offered. And, you know, the qualitative data will show more, but, you know, early explanations could be that there's much better sort of processes in place, contacting processes and recall processes for the mandated appointments than for the additional appointments that were added with Best Start for Baby. So really interesting to see that sort of pattern across these appointments. And looking a bit more about how the appointments are taking up across different demographic groups and localities. Interestingly, engagement was broadly similar by gender, ethnic group and deprivation. There were some differences based on the location of the borough, but they weren't really statistically significant, and it could be due to simply ward level differences in recording local pathway processes and population movement. So I guess that shows the importance of qualitative data, speaking to those groups, also feedback from the public involvement group, and possibly thinking a bit more about intersectionality and being a bit more specific about the sort of ethnic groups or different parent groups that we want to get insights from. So moving on to the qualitative data, thinking more about the barriers to service engagement. These are early findings from the qualitative data, and one of the barriers is lack of awareness of the appointments on offer. This is because of not being contacted, not being followed up to book, and there could be some logistical issues with this. I'm very aware that in Camden there's several databases to record attendance, different admin teams depending on what appointment it is, and it's hard to get the messaging and the language consistent. So that could play into this. Then limited understanding of what appointments involve and what the benefits of health visiting are. Again, that's something the public involvement group really stressed, that health visiting seems to be a bit of a mystical thing amongst parents, and it's not really talked about that much. So people don't really know what to expect and why there might be a benefit to the visits. The availability, location and time of appointments wasn't always helpful. Too far from home. For instance, someone from the public involvement group recently said, you know, it takes 2 hours to leave the house for a 5-minute appointment. It's really difficult. And then language barriers, especially challenges with existing translation services. And these, you know, the majority of the barriers do disproportionately affect the 5 target groups that we looked at earlier. When people do access the service, the feedback has been really positive, and people especially really valued the health visitors, and the sort of prompting about talking about mental health, and they felt safe asking questions and asking for help, which is really great to hear. Parents really appreciated the content and breadth and the number of appointments, and they also appreciated the linking between services, especially other Best Start for Baby services or wider services. So that's about it. Those were the early findings. The quick summary is about 2/3 of children attend, so there's full engagement. whilst only a third partially attend. The attendance which is higher at mandated appointments compared to the additional appointments. There wasn't a huge difference between gender and broad ethnic group, but a level of deprivation, and parents, if they were able to access the service, really thought it was really good. And the report should be out sort of end of summer, sort of autumn. So if you're interested in getting the full report, drop me an email. I'll put your email in the chat and I will send it to you. So thank you very much for listening.
Thank you, Sarah, that's great. So I will bring Nathan in now for Nathan's presentation, and feel free to keep posting in the Q&A chat, and then we'll do question and answers after Nathan's slides. Over to you, Nathan, thank you.
Thanks very much, Lorna. Real pleasure to come and be part of the webinar today. A lot of my career has been in local public health, but I've been involved in academia last few years, and it's brilliant to be presenting on this additional review in Rotherham. Just some of the team listed there. I just want to give a special shout out to Pam at the bottom right there, who led our public participant work. Fantastic involvement from local families and third sector in guiding the evaluation and helping getting involved with recruitment, publicity, all that sort of stuff. So an enormous thanks to Pam and the team for that. So a little bit of background for us. So there was a Public Health England, remember them, evidence review a few years ago, where they identified that there was a gap between the 6 to 8 week visit and the 1 year review, and it was too long for a lot of families potentially, and they said 3 to 4 month visit may be beneficial. And there's some history of that visit existing in England. It was often known as the weaning visit, and some sort of qualitative evidence show that staff remember it quite fondly as it being an important contact point to speak about weaning, but also a host of other things too. But there hasn't been much recent evaluation of adding a visit at this point in the schedule. In came Rotherham, September 2023, they piloted the addition of the universally accessible 3 to 4 month visit, and it's delivered by nursery nurses. It's delivered in the home primarily, and it takes about an hour, so it's a bit longer than some of the other visits as well. And the general rollout to the whole Rotherham population began in January 2024, once they had their full complement of nursery nurses. And some of the key topics they would cover would be breastfeeding, home safety, safe weaning, and parental mental health. But it was also guided by parents as well, what they would want during the visit. A little bit of background on Rotherham, quite an interesting contrast in Camden, about 250,000 people living there, much more settled population in Camden, about 90% white, but a 5% minority of the population identifying as Asian or Asian British. And you can see from the sort of deep purple on that map, you know, quite a few significant areas of deprivation across the local authority area. So ably illustrated by our babies, the aim of the evaluation was to look at reach, effectiveness, and acceptability. So who does the visit engage with, demographics, some of the sort of similar stuff that Sarah was looking at in Camden. Effectiveness, ages, what about impact on ages and stages, scores, parent knowledge, onward referrals, and also acceptability. You know, what do parents think of it? What do staff think about it? And what are the barriers and facilitators to having the visit, and for staff, and from the staff perspective of implementing it. So we'll start with reach. The way we had a look at this was we took the routine Rotherham NHS data from the trust that delivered it, Rotherham NHS Trust. We went from January 2022 to Feb 2025, excluding pre-2022 because of COVID and the impact that would have on the data. And then used a statistical method called multivariate logistic regression to try and identify which family characteristics were linked with families taking up the service, and also whether maternal mood was recorded or not. We wanted to look specifically at maternal mood, but because of data linkages and things like that, the best we could do was whether mood was recorded or not. So you can see from this chart, the yellow line is the 3 to 4 month visit, and it shoots up to 80% and then stabilizes. And that's about 15 percentage points lower than the mandated visits at 8 weeks and 9 to 12 months, which are about 95%, and that's about 200 babies each month for the team to visit with their families. Really positively, we did see equitability of visit access from deprivation level from postcode data, no clear trend across most of the deprived leased areas. Also, no differences found in ethnicity or maternal age, but we did find that families with more than one child had about a 70% lower odds of receiving a visit, and the qualitative work suggested that might be because they felt more confident in the early stages, but also in terms of being able to organise a visit and that side of things too. So maybe a couple of things going on there. In terms of maternal mood recording, that was equitable again across deprivation quintiles and across ethnic groups. But maternal mood was more likely to be recorded with increasing maternal age. So each 5-year age band, you saw a doubling of the odds of mood being recorded. Essentially, younger mothers less likely to have their mood recorded. And also women who had been pregnant before were less likely to have their mood recorded, 22% lower odds there. On to our effectiveness now. So looking at the ages and stages questionnaire, so this is something that's completed with families. There's a bit of an explanation here. So there's 5 domains, each are scored between 0 to 60, 6 questions for each domain worth 0, 5 or 10 points. So using sort of the validated scores, this question has been, academically evaluated. Those scores could put a child into the below cutoff place where potentially there's a delay there, they might need referral to assessment. The monitoring section where they get, maybe a little bit of additional support or monitoring or on schedule. So firstly, we looked at if the visit was associated with the proportion of children in that green on schedule bracket. And we found that children offered the additional visit had a 40% higher odds of on-schedule problem-solving development at 9 to 12 months, which is that green line there. The other domains, you could see there's sort of some estimates of small improvements, but because those confidence intervals overlap the line where there's no difference, we're much less confident that that's an actual association. I'll touch a little bit on the limitations of this a little bit later, but problem-solving there, you can see a 40% association improvement for those who were offered the visit. And the second one we looked at was the ages and stages, adjusted mean difference, which basically looks at the total point score on average for the children, and comparing those who are eligible for the visit and those who were born before it was introduced. But again, for both of these measures, we're taking into account the child's age, the mother's age, ethnicity, all those sorts of demographic factors in the model. And here you can see an increase of about half a point for problem solving and personal social. That was statistically significant. There are bigger differences in communication and gross motor again, but because of the confidence intervals overlapping, we could be a bit less confident about those. So it's a small difference, 0.5, but it is a difference that we've spotted. On acceptability, this was answered by our qualitative work. So there were 15 interviews with parents and a couple of focus groups as well, one at a playgroup, one at a mosque. And then we also had focus groups with staff members who were delivering the service and local authority members who were commissioning the service. And essentially we use a framework that tries to get to the hub of what actually is working about this intervention, what doesn't work, what is it about the context that means this is why it's happening. So it's kind of getting to the how and why questions. So parents generally really valued having this extra time to discuss their child's development. They appreciated discussing weaning. Some thought it maybe should come a little bit later, the parents, but the staff were really keen to emphasize that actually a lot of people start weaning a little bit early, and actually the 3 to 4 month point is a really good moment at which to have those conversations before people dive headfirst into early weaning. And some improved confidence described amongst parents. Perhaps unsurprisingly, given what we found with the maternal mood recording, some felt maternal mental health was a little underexplored. Some excellent examples of rapport being built by nursery nurses, described by parents, 1 or 2 parents describing feeling a bit judged and that undermining the rapport that they had. Service signposting came up again and again. People were at a moment at 3 to 4 months where they were starting to think about where they could go out with their baby and support their development in groups and things like that. So they found it a really useful time to find out what was available locally. But there was a little bit of confusion about exactly what the purpose of the visit was. So I think that's a nice quote there that illustrates the fact that the text just had a link and that was it. So perhaps that might explain a little bit the difference between take-up rates. And commissioners were supportive of the visit, but it was externally funded at the time, so that was undermining their confidence a little bit as to whether they could sustain the visit, even if it did evaluate well. A little bit on cost, how many coins in the piggy bank it requires. So there were 3 additional Band 4 nursery nurses who were introduced through a contract variation to deliver the service, and you can see it cost roughly between £120,000 and £140,000 per year. So reflections, most parents valued the visit and they found it reassuring. There was tailored developmental advice, the really important local signposting, but they did feel that the purpose of the visit could be made clearer. It did appear to be culturally tailored, and it had equitable take-up across ethnicity and deprivation levels. Some evidence here of an association with improved problem-solving skills particularly, but the way that the study design means that it's possible that these changes could be explained by other things like changes in national policy or just trend over time. Perhaps babies in Rotherham would have continued improving their problem-solving anyway without the intervention. So we can't rule those things out. And I think it'd be really valuable in future to look at things like infant feeding data, immunisation rates, and all referrals, which was data we couldn't collect in this instance. And we've seen from the chat lots of areas are doing this, so it'd be amazing to do this sort of research. Also look at things across multiple sites too. So our full report is available on the PHIRST website. Click on that link. I'll also put it in the chat. And so we're hoping for it to be published very shortly as well too, in our academic journal.
Great, thank you.
Just navigating my way back to the control bar to try and turn myself off.
Thanks, Nathan. And I think just to add to Nathan around sort of what impact the first evaluation has had in Rotherham and what we've done next. So we're obviously at a stage now where we've got a finished evaluation and some findings, and I guess really grateful to have that first support in the team. We wouldn't necessarily have been able to do the much richer qualitative data analysis that we were able to with the help of the first team. And I guess in Rotherham, we also felt it was really valuable to have an external evaluator looking at this outside of our organisation. I mean, in Rotherham, we were really keen for this to work for our residents. We obviously put budget towards that, but actually having that external third-party view was really helpful in terms of some of that rigour and being able to use that moving forward. Probably worth mentioning that the application was pretty straightforward and it wasn't necessarily any more time intensive to conduct and work with the first team. We would have had to do some sort of evaluation anyway, so we just sort of displaced that time and were able to do that more collaboratively with a wider group of people. And really exciting that universal rollout was originally funded for 2 years, but actually based on the evaluation findings, we've been able to fund for an additional 2 years. So that's 4 years in total. And we're looking at now maybe embedding that into future options. So still exploring options of what that looks like post that 4-year period. And I guess really exciting for us in Rotherham that we're at the point now where we're starting to see some of the data from our 2 to 2.5 year checks come through of the cohort of people that originally had that 3 to 4 month check. So we're hoping that we can build even further on this evaluation, looking at the 2 to 2.5 year checks in addition to those 12-month outcomes as well. So yeah, big thank you to Nathan and the team. Really valuable for us in Rotherham to be able to use some of that. So we are now into Q&A. So we've had a couple come through on the Q&A chat. So I'll go with the most voted, which I believe is for you, Sarah, but who is delivering each contact and what are the caseload sizes like?
Yep, I think I'll bring in Susanna if that's okay, because she's a bit closer to the to that side of things. I'm just going to see if I can unmute her. Oh yeah, Susanna?
Yep, hello.
Oh, hi.
Hi, everybody. My name is Susanna. I'm a data analyst in London Borough of Camden for early years, and I'm an embedded member with the PHIRST research team as well. So with regards to your questions, all of the additional contacts are delivered by health visitors, apart from the 9 month, which is the 8 to 12 mandated contact, which is delivered by the community nursery nurses. And as to the venue, all the additional contacts are delivered in family hubs. And this is, I think, to save time for the travel. So we are able to have an hour-long appointment with the family, and health visitors save time for, commute. And also we are trying to bring families in the family hubs, so to take that barrier of then attending other services, which we know that the families who come to the Best Start for Baby are more likely then to come baby bonding, baby play, and all the other services delivered through family hubs. So they are not home visits, they are community venue visits.
Great, thanks, Susanna. Nathan, did you want to add anything about Rotherham, the delivery of the contacts?
Yeah, I think I described it a little bit. It's delivered by nursery nurses, and it's largely at home, which I think a lot of parents really valued, made it a lot easier to organise. There was one slight issue, I think, because a lot of the earlier contacts are delivered by health visitors. There was parents talking about the lack of continuity, so they'd just seen someone else at the 6 to 8 visit, and then they're going to get the different face comes through the door at 3 to 4 month visit. So that's perhaps one of the drawbacks of that model, is continuity is harder to achieve. So yeah, do you think that is anything you'd like to add, Lorna, as well, obviously from a Rotherham perspective?
No, I think that probably covers it. Thanks, Nathan. And I think we've maybe touched on Sarah in the chat asked an additional question around sort of where those appointments are done. So I think we've probably answered that, and our Sarah has put a link to further information on that one. But if Sarah Catton, if you feel that's not answered, just drop me a little comment on there and we can revisit that one. Thank you. The next question, is there an answer to the issue of access to services? Many local authorities are closing local venues or not affording Best Start premises in the hard to reach areas. Did either of you come across that? Yeah, sure, go ahead, Susanna.
So we have established 5 family hubs that were children's centres for many years, and the main reason I think we are able to extend the offer is through the family hubs funding, which we are now in year 5. The focus on perinatal mental health and parent-infant relationship, this offer sits bang on in the middle of that. So we have central government funding, and the family hubs are very much needed, and it's the political support of continuing to have children's centres, family hubs is very strong in Camden, so we're lucky in that aspect.
Yeah, thanks, Susanna. And Rachel just added a comment on there around are any other areas using other community venues as they're struggling with space in family hubs? So I guess others on the call, feel free to, if you're using alternatives, to maybe drop a comment on there so Rachel can have a little read of those. What was the rationale for adding the extra visits, and how did this improve children and young people's health, i.e. increase breastfeeding rates?
Yes, I think that was, obviously, Lorna, you were part of the decision making for introducing the visits, but that 3 to 4 month point, as I said, was known as in years gone by as the weaning visit. So that was quite a strong part of the rationale, wasn't it? But also immunisation and just supporting people to find opportunities to help their child's development and give them tips or ways that they could do it at home and things like that as well. I think just to wrap up with that, some of the other questions relating to vaccination and immunisation, that was something we'd like to look at. We wanted to look at, but the way that the records were held was they were separate from that main Healthy Child Programme data set, and there wasn't a way of sharing across to us. And the other thing with the first evaluations is you basically, when you start, the clock starts ticking. You have a year, and it has to be wrapped up within a year to make sure that the first teams can give then support to other local authorities for other ones. So there's all these additional things sometimes that would like to be done, like going back in and having a look at immunisation rates, but it's just not feasible within the year time span that you have to do the evaluation. So sadly, we didn't get to look at immunisation data.
Yeah, thanks, Nathan. And I think a bit of that rationale as well is we'd had some feedback from families that actually the gap between that sort of new birth visit and then through the next visit was almost too long. And at that new birth visit, perhaps it was quite difficult for people to sort of register some of that information and remember that for the future. So actually that 3 to 4 months felt like a nice intermediary to be able to revisit that and pick up on some of that information, particularly around sort of weaning, safety, etc. Have you, oh, so we've covered the vaccination one. Do you have to be registered with a GP in order to receive comms for appointment post-birth? Some families will, or babies will be missed. No, so the way that you get it is through your health visitor, Sarah, so you'd get the comms through that route. So they would go out for us via our trust, which I presume is similar in Camden, Sarah, Susanna?
Yes, so the new births, we have information sharing agreement with health visiting who get notification from the maternity wards, and then they notify us, the local authority. For the movers in, families, if they come into the area but don't register with GP, so they are still registered with their old borough, we would not know they came in, because until they register locally, then health visitors are notified and then we know as well. So yes, you'd have to be registered if you're a mover in.
Thank you. Louise, did the additional funding for the extra visits and staffing resource all come from the NHR first team, or did the public health team need to contribute? So no, the first team don't fund the intervention. The local authority applying for the first evaluation has to fund that. So the public health team in Rotherham paid for that. However, the first team provide a free evaluation of that. So the public health team need to front the funding, but the first team will support with the evaluation of that, which is the same for all of them, all the first interventions, I think. Is that right, Nathan?
That's right. Yes, it's just the evaluation itself that's funded by NHR.
Right, thank you. Another question, health visitors where in working also mentioned that there's a big gap between the 24-month check and the start of school. Was an extra visit during this time around school readiness discussed at all? Sarah, was any of that discussed in the Camden work?
Sorry, should I take it?
Yeah, sure.
Is that our initial thinking was the focus on the first 1,001 days, with the idea that early identification and also, the early intervention would support also the knowledge of parents to look for support if needed. And then also because of the 2-year free funding for the nursery places, we have a lot of the children are already in the nurseries where the practitioners pick up issues around, the child's development is being discussed in the settings. But we're not thinking about currently extending the Best Start for Baby offer to beyond 2 years. Yeah.
Thanks, Susanna. There was a question around, we mentioned around potentially looking at immunisation rates in the cohort who had had the additional visit. Has it started and has there been any impact? This has not started. It might be something that we're able to look at in Rotherham in line with looking at those that receive the 2 to 2.5 year checks. But we just need to work through a few things around the data sharing and data linkage to be able to do some of that, I think. But we've not started it to have any initial findings at the moment. Nathan, I guess, what does it mean for other local authorities considering an additional visit for the Healthy Child programme?
Yeah, that's a great question. I mean, there's clearly so many areas that are doing this sort of work at the moment. So there must be there's a lot of learning out there, I think. You know, there's obviously the stuff that we've done at PHIRST, but there'll be plenty of things that aren't necessarily publicly available that's worth finding out about. I think specifically from the Rotherham experience, I think you can draw the conclusion that it can be really well received, and the staff actually really enjoyed delivering it as well, which I think is quite important, that staff found it a really valuable experience to be doing these visits, that there's potential to improve confidence, potential to give really good advice on supporting child development, and they can have, I think 80% for a completely new visit is still, you know, that was fairly equitably received, is still really encouraging, I think, so that you know, they can be taken up and they can be delivered equitably and culturally tailored, and they're certainly definitely worth considering as part of your approach to healthy childhood.
Thanks, Nathan. And Susanna and Sarah, the invites for the non-mandated appointments versus the mandated ones, were the invites sent out the same? Did they sort of read the same text message, or were they tailored differently?
They're slightly different. Children Centres Family Hub's admin team invites families to the 3, 6 and 12 months appointment, and we send out email, then we send text message, and if parents haven't booked themselves, then we also follow up by a phone call, whereas the mandated invites go through health visiting admin team. So the route is slightly different, and clearly it's resources, because we don't the time just to call everybody, especially. So we're trying to get the 3 month appointment as high as possible, because as soon as families know at 3 months what the appointment is, how useful it is, how to get to the venue, then the follow-up appointments are attended more easily. But it is still a working process. It's yeah.
Thank you for that.
So I also just want to say this is how valuable the first evaluation is, because it's having someone outside of the council, because we're too close to it, and just having that objective view of researchers highlighting where the need is to make this really work is really, really valuable. I cannot recommend enough.
Yeah, thanks, Susanna. I echo the thoughts from Rotherham too. Has there been any discussion in Camden about looking at additional cohorts? I mean, you talked about the 5 groups there. Was there any additional that you felt maybe could be picked up if you were able to do this again?
Shall I go, Susanna? Or maybe both of us, be good to get your perspective as well. It took a while to get to those 5 cohorts, and that was based on a kind of a small scale study that Camden had done before. So we tried to make it as sort of evidence-based as possible, those cohorts. I think a surprise in the current data analysis is that there isn't that much variation based on ethnicity or deprivation. So I think that's something to look at closer before any more work is done, and to better really understand why that might be the case. Are we zooming out too wide? Do we actually need to look at much more specific stuff? Do we need to look at intersectionality, things like that? So I think that's probably, in terms of next steps, that's what I would be looking at. But Susanna, it'd be good to get your perspective as well, because you were involved in kind of selecting those 5 cohorts.
Yes, so Camden is a bit of an anomaly in England, because I think everywhere else, the higher deprivation, the less of engagement. But we have strategically placed our children's centres in the most deprived areas, where, as you saw from Sarah's slides, a lower proportion of white British families live. So just the proximity from our previous research shows there's a correlation between distance from the family hub and the engagement. So it looks like we're reaching a lot of families living in top 10 and 20 most deprived areas. We look at the income deprivation affecting children index for that one. And again, throughout the ethnic groups, we have high proportions, but we know that some communities, especially when they're new to England, new to Camden, they don't know what health visiting is. They don't know what the service is. So there's a lot of to do around communication and just knowledge mobilizations among the communities to let them understand this is very much free. It's very much for everyone. It's universal. We want everyone to come.
Yeah, and is it your health visiting team that are doing that work prior to sort of getting the appointments booked in?
So we try to work with midwives. We have 3 hospitals. We have UCLH, Royal Free and Whittington, and we try to work with GPs as well. So the families here on multiple occasions. So during the new birth visit, the health visitors talk about the best start for baby appointments. But during the first 2 weeks with sleep deprivation and the shock of having the baby, we know the information uptake isn't the best, so we try to bring it over and over with the families. We have information engagement workers. We have one specifically linked to the program, and she has done lots of phone calls with the group of families who did not book for 3 months appointment. Just calling them and spending the time explaining what it is, what's the benefit, how to get to the hub, and trying to find out what the barriers are. And we have lots of publicity, website, all the good stuff as well.
Yeah, really helpful. Thank you, Susanna. Another question: did you provide out of hours and weekend appointments for the extra visits to improve accessibility?
We do not. The family hubs are closed, so that's one of the issues. Health visiting contract, again, that would, I believe, require a lot of changes being made, because you cannot just have a health visitor coming to a family hub. You have to have a lot of staff around. So not for that one, no.
And yeah, I was going to say, I'm sure you or Michael will correct me if I'm wrong, but I'm fairly certain they were delivered within hours.
Yeah. Yeah, that's correct. Right, thank you. I think I have done all of the questions now, so if just give it 30 seconds just in case anybody's typing one, but I think that may have covered them. So we'll just take a moment really to say thank you to everyone for your engagement and feedback and comments in the chat today, and a big thank you to Emily for organising the session. As mentioned, it's been part of the LGA's Public Health Lunch and Learn series. So again, there is a link in the chat, so please feel free to have a look at those if you would like to attend any of the future ones. Our next one is the Thursday, the 9th of July, holding a session on From Ambition to Action, delivering the HIV action plan locally. The registration link is in the chat. Just reiterating, we will share the slides from today's session to every registered attendee, and the recording will be available for that as well. So no more have come in whilst I've been typing. So a big thank you to Nathan, Sarah and Susanna for presenting those findings and answering those Q&A. Thank you everyone else for your time and engagement, and have a lovely day.